Hello, my name's Andrea Strong. Like she said, I'm a nurse at Rush University Urology. I do have some experience with urodynamics. I was fortunate enough to learn urodynamic studies from Lori Cornelius. Today I'm just going to share with you a couple basic things. A few of these are reviews that Lori covered, but mainly I want to focus on the tracing piece. So what are the common tracings that you may find that are associated with common diagnoses. I really want to emphasize getting a health history for your patients before starting the urodynamic study. You really need to know what it is that you're looking for in a urodynamic. So I usually talk to the urologist or read the notes. What exactly are you looking for here? So you can seek that during the urodynamic study. I really love urodynamic studies. It gives you an hour, sometimes an hour and a half uninterrupted time with your patient. You really get to learn more about them, more about their symptoms, and engage in a lot of therapeutic communication. All right, so let's move forward here. So again, Uroflow Basics, I think we all know what Uroflows are. We have many in our clinics, different types. According to the literature, you should have at least 150 milliliters in order to get an accurate pressure flow. I work with urologists who will take a little bit less than that, depending on the patient's symptoms. Just a quick review of Uroflow Basics. We have the flow rate, and that's the amount of urine coming out per second. Then there's the maximum flow rate, and that's the highest level of flow sustained for at least 1 second. You also have an average flow rate, and that's the total voided volume divided by the time. The average flow rate is not accurate if your patient has an interrupted flow. So if you have a guy with an enlarged prostate who's peeing and then stopping and then peeing and then stopping, your average flow rate is not going to be accurate. And then your voiding time, this is the amount of time that it takes for your patient to complete their void, and that includes periods of interruption. Okay, so if it's a stop and go urination, this will include that piece. Flow time, that's the total amount of time that the actual flow includes. So they're going to subtract periods of time when the patient's not urinating. And then the time to maximum flow, so that's the amount of time it takes for them to reach that peak flow and hold it for 1 second. And then, of course, your voided volume, just the number of milliliters that the patient's voided. Okay, normal male uroflow, this is going to be a little bit less than a female's uroflow because they have the longer urethra, but we're looking at somewhere around 20 milliliters per second. And then your normal female flow, which is a little bit faster. Females have a shorter urethra, it's 4 centimeters. Also, the urethra is straighter in women, so you're going to see a little bit of a variation there. So this is normal tracing. This is a little bit more of what we might call a super flow because the maximum flow rate is 40 milliliters. So you're looking at decreased outlet resistance. This is actually a male uroflow who had a HoLEP done, so his prostate's out of the way and he's voiding pretty quick there. This is more of a normal flow. This is a female patient. Maximum flow is 19 milliliters per second, and the volume is 253 milliliters. So this is, like Lori said, this is a nice bell curve. That's a normal flow. I had a hard time in the beginning understanding the difference between an interrupted and an intermittent flow. So this is an interrupted flow because the urine stops and starts and stops and starts, and that's in contrast to your intermittent flow. There is a little bit of interruption at the end, but you can see, let's get this laser pointer. Here, it's just kind of, it's not smooth. So this is what you call an intermittent flow. So now we're going to get into the tracing pieces here. So I'm just sort of covering the basic stuff. So these are things, these are normal tracings and normal urodynamic studies. So capacity, 300 to 600 milliliters, ideally. Sometimes you won't reach that with patients with certain diagnoses. The compliance, so the bladder is going to fill, and I listened to a presentation with Michael Gray, and he had a great, Michael Gray. He had a great analogy. He described a good compliant bladder is like a very thin balloon that you can blow up, and it opens up easily to accommodate the air. And then a non-compliant bladder or low compliance is if you had like a leather balloon and you're trying to blow that up. The pressure is just getting higher, but it's not expanding to accommodate that airspace. So that's what we mean when we're talking about compliance. These are some pressures. So if you're doing a urodynamic study and the patient's, bladder pressure starts to raise, it's safe if it's under 20, and if the detrusor pressure is between 20 and 30, you're getting into the danger zone, and then anything above 40 is considered, high risk for the kidneys. So, at 40 centimeters of water or greater, the kidney is not able to produce urine. So anything above 40, we call a hostile bladder. So if you have a patient and the pressure keeps going up and up and up and up and it stays up above 40, you should drain their bladder and stop the test for their safety. And then we talk about sphincter competency. So looking for stress incontinence or intrinsic sphincter deficiency. That's another piece that I had a hard time understanding at first. So normal urethra is going to stay closed like this. If they have an intrinsic sphincter deficiency, then that urethra is just kind of open. And that's where you'll see low leak point pressures. Your sensations. So your first sensation is their initial perception of, yes, I can feel something going into my bladder. Your first desire average is between 90 to 200. Strong desire average for a normal patient between 300 and 600. And then when we talk about capacity, that's when the patient's like describing an emergency. When we talk about detrusor stability, we're seeing if the bladder remains relaxed while being filled. So bladder should not be contracting while the bladder is filling. If it does, then we might call that an unstable bladder. Oops, forgot about that. EMG, that's the little stickers that you can put on to the patient around the rectum. And those are going to take a look at the sphincter, the electrical activity of the sphincter and the pelvic floor. And then ideally your PVR, your patient should be emptying completely, so PVR of 0. So I had a hard time finding a normal urodynamic study, no surprise. So I borrowed this from the core. And all of them are set up a little bit differently depending on your machine, so everything will be in different orders. But this is here, this is the flow, so that's kind of a nice bell shape there. Your volume is 262, so that's normal. PAB, that's the catheter that's in the rectum, monitoring the abdominal pressure, that's pretty low. And then the vesicle pressure raises, while the EMG down here remains quiet. And then, so you have your abdominal pressure minus your vesicle pressure. The difference between the two gives you the detrusor pressure here. So this is a normal flow. So we're going to talk a little bit about the difference between abdominal events and detrusor events. This is also a Uroflow that I borrowed from Michael. You can see A here, this is an abdominal event. That's the volume. This is the abdominal catheter. This is the vesicle catheter. And you can see these match each other. Okay, so the patient's coughing, the two are matching, it's an abdominal event. If you look at B here, the patient is doing a Valsalva maneuver. These two are matching. This is an abdominal event. Why? Because your vesicle here is completely quiet. C is the patient coughing again. These two mirror one another, and your green line here is quiet. Now D, that's a different, D is a detrusor event because your vesical catheter is detecting a raise in pressure, and your abdominal catheter is quiet here. So D is your detrusor event, and the rest are abdominal events. So this blue line here is your abdominal catheter. Can anyone guess what's going on here? This is peristalsis. Okay, so you'll see sometimes that'll throw you off if you see that. You're going to see the peristaltic waves there during a urodynamic study. Again, here A, B, and C, those are describing, contraction of the smooth muscle in the rectum. That's peristalsis.
The reason you know that is because the vesicle is flat.
That's right. Yeah. Yep, so this is the vesicle up here is completely quiet, but your abdominal catheter is picking up these waveforms here of the peristalsis. And now we're going to talk a little bit about detrusor events. So you can see here, this patient is having, the blue is our abdominal catheter. See better here. The top one, the pink one, is your vesical catheter. Green is your detrusor pressure, EMG, and then our flow rates at the bottom. So our patient's having an uninhibited contraction here. Why? Because you can see that the abdominal pressure is quiet, but we have a raise here and a raise here. Same thing right here. And the patient is, confirming that they're feeling these sensations. There's no leaking associated with this one. And then again here, this is our abdominal catheter, completely quiet. Patient's having an uninhibited contraction. We have a raise here in the detrusor and the vesical pressure. This is a little bit of what we call guarding. That's a normal response. So patient's having an uninhibited contraction. They're feeling like they have to go, and they're holding their pelvic floor in effort to keep from leaking. So that's a normal thing that you'll see. Outlet obstruction, this is a common tracing that you'll find a lot with our male patients who have an enlarged prostate or maybe have some scar tissue. This is your classic high pressure, low flow. Abdominal catheter is quiet. Vesical pressure here is high. Detrusor pressure is high, but the flow, I think the maximum flow that this patient had was 6. So that's a really low flow here. This is not a nice bell curve. It should be matching, going like this. So that's high pressure, low flow, bladder outlet obstruction. This is another example on bladder outlet obstruction. You can see here the vesical catheter is here. Your detrusor pressure is in red. And your flow on this one is on the very top. So high pressure, low flow. An acontractile bladder, so sometimes the patient has a neurologic disease, or maybe they've had long-standing obstruction and their bladder's not working anymore. It's like, sometimes I describe it like congestive heart failure of the bladder. It's just a big flabby bladder that's not contracting well. You can see some tracings like this. So this is a patient who was given permission to void. Nothing was happening. So this gentleman started to use his abdominal muscles here in the blue to attempt to void. So he's like really working his abs to try to empty the bladder. And then you can see these little blips here, little flow, little flow, little flow. So he's not mounting any detrusor or bladder pressure of his own. He's using his abdominal muscles to squeeze that out. This is another example of a patient who was given permission to void. Nothing was happening, nothing was happening. They're using their abdominals a little bit here, but you can see these pressures are really low. This is the detrusor pressure. These are low. And you get a little bit of a flow here. It's prolonged, intermittent, interrupted flow there. Low bladder compliance. Low bladder compliance can be caused by sometimes alcohol, diabetes, or a spinal cord injury. This is an example that I borrowed from the core. On the top is your vesical pressure. In the middle, your abdominal pressure, which is quiet. And on the bottom is your detrusor pressure. So as we're filling the bladder, it's not expanding to accommodate the space for the urine. So the pressures just keep going up and up and up. And then if this happens, you need to stop the test, drain the bladder, because you're putting their kidneys at risk. Took me a long time. I think we've only had a couple patients with non-compliance, but this is a patient with a non-compliant bladder. Your abdominal pressure here is quiet, but your vesical pressure and your detrusor pressure are just going up and up and up to about 50 centimeters of water for this patient. Now, like I said, that's dangerous for their kidneys. This is another term that I had a hard time with, so I wanted to clarify. Dysfunctional voiding or detrusor sphincter dysinergia. So this is when you're seeing increased activity on those electrode patches, the EMG patches. If they have a known neurologic disease like multiple sclerosis, we're going to call it detrusor sphincter dysinergia. If they don't have a known neurologic disease, then we're calling it dysfunctional voiding. That could have been a learned habit that the patient picked up over the years that we need to work to correct. So this is an example from the core on this case here. So you can see this is the EMG, the electrode patches down here, and you have a lot of increased activity. This is your flow here. A lot of increased activity as this patient is trying to void. So you'll see it should remain nice and quiet while the patient's trying to void, but instead we see all of this down here. So we're just going to go briefly over some case studies in our clinic here. So this is a young woman who has multiple sclerosis. She has a lot of incontinence. It bothers her, you know, she's wearing pads and it's embarrassing. She doesn't like it. She was treated at an outside facility. They took her through all of the drugs and all of the steps that you can take for OAB, and now she's interested in Botox. So she came to our clinic. This is the very beginning of the study. So this is the patient coughing just to make sure that our catheters are in the correct space, and immediately she has a big uninhibited contraction with leaking, and so we were able to get our diagnosis here, and we did treat this patient. She's I think it lasts about 9 months for her. We give her 100 milligrams of Botox in the bladder, and we actually put her into complete retention on purpose, and she catheterizes, you know, every 4 to 6 hours, and she's very happy with this treatment option. Case study number 2, this is a 28-year-old female. She came in with urinary retention. She had a catheter in since June of 2016. She does have a history of metastatic chondroblastic osteosarcoma complicated by cauda equina. And she was very unhappy with this catheter being in. She wanted to remove some of her drains. She did decline further treatment, but we really wanted to, you know, help her improve her quality of life. So we did a urodynamic, and just a review on that cauda equina, that is some swelling and pressure on the nerves at the end of the spinal cord. So that was causing, you know, contributing to her difficulty urinating in addition to the narcotics and all that. So this is her urodynamic study. We gave her permission to void. Nothing's happening, nothing's happening. So again, She's using her abdominals here to try to push the urine out, and we got little baby flows down here, just, you know, drip, drip, drip. So the treatment for her, we removed her indwelling catheter, improving her quality of life, and we taught her how to do clean intermittent catheterization every 4 to 6 hours. So she was pretty happy with that solution. So I have some tips for the novice urodynamicist. The study should be repeated until you get a valid reproducible result. So if the patient, let's say, has showing uninhibited contractions and they're leaking everything out, terminal leaking with an uninhibited contraction, you should fill them a second time. And when I'm documenting that, I usually put first fill, second fill, third fill, so that you can make sure that this is actually the result that we're getting from the urodynamic study. You always want to check a dipstick first, just to screen for infection. If they do have a active urinary tract infection, you don't want to do that urodynamic study because you can run the risk of, introducing bacteria into the bloodstream, causing sepsis. There are a lot of medication considerations that you should make. So if a patient's on a diuretic like Lasix or something, you may want to talk to your provider about whether or not they should hold that, because that can cause a lot of frequency and urgency by itself. So you may want to time their diuretics appropriately. Also, sometimes we're doing urodynamic study to see if a medication is working correctly. So you want them to be on their Vesicare, their Mirabetril, or their oxybutynin, whatever it is. And sometimes they want to see what the bladder's doing all by itself, so we'll take them off of those medications a couple days ahead of time to see what the bladder's doing. So make sure you know what the expectations are on that day of the urodynamic study. Again, be aware of their history. I always browse their chart first before even bringing them back into the room. If you're new to urodynamics, you should know about autonomic dysreflexia. This happens in patients with spinal cord injuries T6 or above, and this can cause severe headache. They'll get really sweaty, they'll have a strong feeling of anxiety or impending doom, and their blood pressure will skyrocket. So when I have a patient with this kind of history, I keep the blood pressure cuff on their arm and I check it throughout the study. Most of these patients, if they've had, have issues and they have autonomic dysreflexia, they know what it feels like, they know when it's happening, and they'll let you know. So monitor their blood pressure. If they do start having, headache, anxiety, their blood pressure goes up, they start sweating, feeling uncomfortable, you need to drain their bladder immediately because they can, this can last for up to 24 hours and cause a lot of problems for them. So be very cautious with these patients. And don't forget emotional, that's supposed to be support for your patients. All right, so we have some significant time for questions now, so Lori's going to join me, and we'll answer all of your questions on urodynamics. Thank you.
Now, did you give antibiotic prophylaxis after the procedure?
After the test?
After that,
Yeah, it's quite common. It just depends on your provider. Many people do it, some don't, but yeah, there's nothing wrong with that. Absolutely, either prior or after. Often you see that.
What was the question? What was the question?
Oh, can you give antibiotic after the test?
For females, is it allowable to do a vaginal pee abdomen? So instead of putting the catheter in the rectum, you put it in the vaginal.
Yeah,
for
you can.
females, is that acceptable?
Yeah, most people, I'm surprised at how well, though, that people tolerate the rectal catheter. Actually, they tolerate that one better than the urethral catheter. So I try to talk to them about, I like using the rectal catheter simply because it stays in place better usually, but you can use the vaginal for sure. There's nothing wrong with it at all.
When you're doing one on a prolapse, are you doing the test, the full test twice?
No, sorry.
That's what we do. We reduce it, do the test, and then we do it next.
Well, you can. I mean, there's nothing wrong with that. It's just, obviously time consuming, but what I usually do is, like I don't know if you caught what I was explaining, but I just do their cough leak test or Valsalva test 2 times in a row each time I do it. So I will do the initial cough, valsalva cough, while I'm watching, and then I will repeat it right after I'm done the first one. Then I reduce them and have them cough.
You're reducing them, are you having them stand?
Stand to do?
To reduce it, like if you're having them stand to cough, or you're just having them
Well,
cough?
if you have it, right, so you keep them in the same position, whatever position you originally are having them do it in. So I've done them standing, we've done them standing many a time, just reducing them. I manually reduce. I think that's easier. I think you get a better feel for where you are. You're not, putting pressure on the urethra, so you're not blocking. You're trying to see that leak if it's going to happen, and if you're putting more pressure on it. That's why I don't like using like gauze or anything like that. A lot of people do that. I'd rather just feel it. But yeah, you can get a decent feel and a decent reduction by doing that, standing or lying down.
Do you like to get the flow at the end though, the pressure flow with both reduced? That's kind of why we can do tests both ways, because we want to make sure they're peeing okay, reduced versus not reduced.
So yeah, that would definitely present a problem.
Yeah.
For the most part, we're looking at leak. So the flow itself, that you're not going to get a great flow pattern often with a prolapse, right? And I guess more often than not, we just understand that's what we're going to get. We already know they have the prolapse. Most of my providers have looked for, really, they want to know if there's leakage. And so I've not been really concerned, but you're right, the flow pattern would definitely, the pressure flow would be very different with the prolapse there as opposed to it not being there. But that hasn't been as big of a question, but that'd be the most ideal way to do it, is to refill them, at least just to get a second pressure flow with reduction. It's really provider, what is asked, yeah. I've gone out and taught a provider, set up their urodynamics for them once, and she infused everyone at 100 mLs per minute. Like, literally the tests were so invalid, but it's like her choice. I wasn't going to say anything, so you see all kinds of things. So really just do what's asked of you.
So Lori, if you have someone that you know has a small bladder capacity, rather than 50, you do 25 or?
I'll go down to 10. Okay. Even, yeah. If I've got small bladder capacity, urge incontinence, that kind of thing, a lot of spinal cord people, because they often react, quite quickly. I will, usually 20 is what I'll start at, but if they start reacting right away, then I'll go down to 10. And yeah, it's usually a long test, but that's why we're doing it. You've got the inconvenience of people being there. They've taken the time out. It's not a cheap test. It's not an easy test. So you try to get as much information, the best information you can. So I definitely will do a slow infusion with anyone that I'm suspected.
Do you make that decision based on the Uroflow that you did at the beginning of the study then?
Usually it's chart review, I make that decision. And just talking with the patient prior to the test, I always say, why do you think you're here? What are your complaints? They can be different than what's in the chart, as we know. So talk with them really about what's going on. That's your key.
So I found when we do them, and they do have overactive bladder or involuntary contraction, as Vic had mentioned, we can have them do a Kegel, and that can interrupt it, and you can continue to fill them. And at that point, I might, if they're very hyperactive, slow them slowly, but not like start right off at 10 or 20 ml. Do you do that?
So the question was, if you have a patient with overactive bladder or instability, you have them do a Kegel to stop that process, and then fill them at a slower rate?
Correct, so that you can try to get
Yeah.
We had a little bit of discussion of that in the first presentation. It has not been my practice to have them do a Kegel in the during the instability. That's why I always start with the slower rate. I feel like that gives them the best chance to get a decent capacity in, you know, in the best test. I'm not using, I do a ton of pelvic floor therapy, and it's so, you know, I use Kegels all the time as far as teaching patients, but as far as during the urodynamics test, I've not really practiced that. I can see where it would be valid, I just don't know the effects it really has. I just use a slow infusion. That's always worked well for me. I think it gives them the best chance.
One other question. How long do you allot per study?
The question was, how long do you allot for a study?
Well, that's another good question. It just really depends. Like, standardly, you know.
Like how far apart do you have to schedule?
Yeah, well, like, depending, most often than not, the general rule for me is about an hour. Okay, so like if I have a stack day, like I've gone to places where I've done 8 tests, you know, back to back. So, and also it depends on your environment. Like I've also done 8 tests back to back in a spinal cord injury clinic, okay? I'm not gonna schedule those an hour apart, right? I mean, these people, I'm putting them in lifts, like, you know, so you just have to be wise about, and I've actually gone back to providers and said, hey, listen, you know, if you have to know also what kind of patients you're scheduling for me, and also think about the people who have mobility issues in general. I mean, you have somebody that's 85 years old and not walking, can't get on a table, can't get on a chair, you can't, and you're usually one person, right? These are good. I love, and this is so common, I think most doctors who say they do urodynamics, and I'm a provider, okay, urodynamics takes 20 minutes. That's what I mean, how often, I've heard that over and over and over again, and it's like, sure it does, when you walk in the room after everything's set up and the patient's under Uroflow and all you're looking at is post-infusion study, it takes maybe 20 minutes. Urodynamics takes about an hour generally. That's just the way it is, and if you've done a good test, that's about how long it should take. It could take longer. Think about the patient who has or needs 1,000 mLs infused into their bladder. That's not going to be like the person who only can take 300, right? So, I think an hour is fair.
Yeah, in our clinic we do an hour and a half because we have our template set up for an hour and a half. So by the time you do the study, clean up everything, reset the room, it's a good hour and a half. But we've had it last 2 hours, you know, if the patient has mobility, it could be 2 hours or longer, 2 nurses, varies greatly.
And it's up to your staffing too. Do you have somebody, like some places have, you know, they'll have people come in and clean up in between you and set up the test for you? That's a whole different story, you know, so it's different everywhere.
I have a question on we do a lot of BPH evaluations, so the big thing I'm interested in is, of course, the pressure flow study. What would you consider the minimal volume to get into their bladder in order to get an accurate pressure flow?
Well, again, 150 is like the mark, but if you've got someone who simply just cannot get that in there, you want at least 150. That's considered a valid flow. But, you know, if you're push, you know, they can have BPH and, you know, instability, and you're, again, reason to do slow infusion to try to get them to accommodate as much as possible. But sometimes you just got to take what you get, you know, so.
Now those are the patients that I was referring to for doing the Kegels.
Right.
Because I found that sometimes, you know, you're filling them, at 50 they start leaking.
Yeah.
So then I started, you can see what it's happening.
Oh, sure.
So you just say, all right, let's go through this exercise.
Yeah.
And then you'll see it come back down and you can keep filling them. And as you say, slow infusion.
Yeah.
But I've been successful at trying to evaluate, like you said, 100, 150 cc's. Otherwise, your voiding is not going to be valid.
Yeah. Yeah. Well, that's why, again, then we have the cysto to that and all those other things to validate the BPH and.
Question?
On the flip side, if you had somebody who says this very non-compliant, how much would you fill before you can say we're not going to go any further? You get to 600 and you're not seeing any response. Do you just stop there or you keep going? I mean, some of you can fill up to 1,500, you know, you let it go.
So your question is how much do you fill in a non-compliant bladder or an overactive bladder?
Non-compliant.
In a non-compliant bladder, once you hit that 40 mark, then the kidneys are at risk. So if it keeps going up and up and up above that, then I would end the test. I wouldn't keep filling them. Yeah.
With your, we see a lot of patients who have had bowel surgeries, resections, and some where they've actually closed the rectum up. And we're seeing them post, usually we'll wait 3 to 6 months to see if the nerves can regenerate. Would it be of any use to do urodynamics? You're obviously not. On your females, we could put it in the vagina and get the pressure put on the male. Would there be any use to be able to look at what the bladder actually does without having an abdominal pressure?
So the question is, if the patient no longer has a rectum, and it's a male patient, so you can't put the abdominal catheter into the vagina, what do you do?
Do they have a colostomy? Yes.
They would have to.
Yeah, you can put it through the stoma. What's that?
Clearance by the surgeon. I have not asked for clearance from, I mean, if they're fresh post-op, I would definitely discuss it.
Yeah, I mean, again, I don't, if your provider can't give you that answer, then yeah, I mean, definitely talk with someone, but I have done that before. I've been asked to do that. So, because I was in the same situation, I was like, I don't want to, but they said just go ahead and use the stoma, you're going to get the same. I've also had someone tell me to tape it to the abdomen. I don't really, that didn't make sense to me, but just to take the catheter near, I don't think that's the greatest answer, but.
How far would you go in like the stoma?
I mean, that would be an individual basis, because everyone's different, but speak with your, the surgeons. I think that's, they'll definitely, most are very happy to give you the information needed to do these tests, because that makes a difference to them as well, what these results are, so I'm sure they'd be happy to educate you.
Find out capacity, the blood pressure, and just
Yeah, you can always do it without the abdominal information. Just make sure that when your providers drop charges, they're not charging for that piece. But yeah, you
still place the EMG pads.
Yeah, you can still place those.
You get some information off the EMG too.
Yeah.
You can see when they're contracting muscles. Make
It
some.
just depends on how much detail they really, some are real sticklers, others are just, I saw the tracing and whatever you report is good.
Do you ever put waterproof tape over those EMG patches?
Question is, do you ever put waterproof tape over the EMG patches?
Answer is yes, for the most part. Yeah, I mean, they get, especially the leakage, that I think is the biggest issue with urodynamics testing is EMG patches. Somebody's got to develop one that can stay on the skin.
Yeah. I find that if you take an alcohol pad and you wipe the area where you're placing the patches first, let it dry, that really helps adhere that patch.
Yeah, I put tape over the top of them always, yeah. I mean, it's fine to fix.
One more question?
Yes, I have some patients sometimes that are constipated or have stool in the rectum. Do you recommend, the doctors sometimes say, why are you putting enemas on everyone before? But what do you recommend?
Question is, if you have a patient that has a lot of impacted stool in the rectum, would you do an enema or have a protocol for enemas?
Definitely. If it's a known issue, then have them do an enema at home or, use something to get that evacuated for sure. Because you're right, it can definitely affect the pressure so yeah, ideally, yes, have them clear it out. If you don't know and they come in, again, talk to your provider, see what they recommend, they're the ones that are going to move forward with whatever treatment is going to happen after that test, so.
Well, thank you.
Oh, we have one more question?
Last question.
Yes.
What do you do with somebody who has an adhesive allergy?
Oh, question is, what do you do with a patient that has an adhesive allergy? I use paper tape.
Yeah, and usually they're fine with the EMG patches. Just, again, latex gloves, all that stuff, you just have to be very careful. Know your patient, read the chart, makes a difference in every aspect of it.